So today we are with Aaron Solwen. It's one of our pharmacists here who is very knowledgeable, and he specializes in behavioral health. And we're talking about depression, anxiety, bipolar, all medications and all of that. And I'm sorry, I forgot to record the beginning of this session, but here we are. We continue, better some than nothing. Yeah, that's exactly what I was thinking. It's like, it's hard when you're out in the community and you hear somebody and how to know, right? And especially with youth, because youth, especially I think adolescents, can be very outspoken sometimes and say things that you don't know if they really mean it or don't mean it. And you have talked about, those people who have already a diagnosis, and those people who can even end up in an emergency room or in treatment for depression and bipolar disorders and major depressive disorders and anxiety. But then I know that there are plenty of people out there that can be either undiagnosed, right? Or they can be diagnosed, and then when the doctor says, okay, I think that you need some sort of medication, people are scared of starting depression medications. Why is that?
Sure, it's a really good question, and it's something that we deal with all the time. We may identify someone has symptoms of depression or anxiety. We have an idea that a medication could be helpful, but there is a hesitancy. There's kind of an uncertainty about beginning a medication. Sure. So I think antidepressants often get a bad rap. I think people, what you do hear about antidepressants are often more so the negatives, more so the side effects, and not so much, the potential benefit. So what I try to tell people is this medication, so let's say an antidepressant, something like a Zoloft or Prozac or Lexapro, something like that. This medication may help you weather the storm of your anxiety or depression. So it's not a magic pill. It's not something that's going to take away these feelings entirely, but it hopefully will give you another tool in your tool belt to help manage the feelings that you are going through. In terms of anxiety or in terms of antidepressants helping with anxiety, especially if someone has feelings of panic attacks and things like that. It's not that necessarily the medication will completely eliminate panic attacks, but hopefully if they do occur, they occur less frequently and they are less intense and more manageable. And in terms of depression, the SSRI, the antidepressants that we use frequently, they just allow folks to get back to the things that they're doing, and allow them to again, begin to get back into their normal routine. But they are definitely just a small piece of the puzzle. And I try to help patients understand that. However, when some people are so depressed, they don't have the ability to take care of themselves. They don't have the energy to eat healthy, to go out and exercise. Their sleep may often be impaired. So an antidepressant can help to regulate those things a little bit faster than if they do not use a medication. Of course, like behavior or therapy, like cognitive behavioral therapy, talking to a counselor or a therapist can be very effective. And sometimes if someone has a mild depression, that may be the first place to start, especially if they have a hesitancy towards medication. In terms of, addressing more so like the fear or the anxiety related to medications, these medicines do have side effects. And a lot of the side effects, when someone begins an antidepressant medication, the side effects will usually come about relatively quickly. So within the first few days of starting a medication. And at times, antidepressants, so like I keep referring to antidepressants, but SSRIs, SNRIs, the medicines that we use as first-line agents, the first week or two on a medication like that can be kind of rough for people. Their body is adjusting to the medication, and a lot of times people will actually experience increased anxiety for the first week or two. And so it's kind of counterintuitive. Like, we're giving you a medication to help to relax you, to help with your nerves. But during the first few days, the first week or so, you're feeling a little bit on edge or restless. And when a patient experiences that, it can be very frightening. It can be frustrating. It can be so uncomfortable that they give up on the medication, and they quickly discontinue it, and that they're kind of right back where they started. So one of the things that I try to educate people on is, yes, when you start this medicine, it's going to take a few weeks for your body to get used to it. You may not feel like your usual self. You may feel a little restless, but over time, most people will tolerate the antidepressant within the first 2 weeks, I would say. That restlessness, that stomach ache, that headache, that uncomfortableness will subside. But you have to kind of get through that first 2 weeks or so. And there are things that as clinicians that we can do to help with that. So the first thing is we start at a very low dose, especially if someone is prone to anxiety. We may start at even half of the recommended dose and gradually increase the medication, so as they can, their body can get used to it. They can develop a tolerability over time. If we were to start a medication at a high dose or a therapeutic dose right away, that's when the body says that I do not like this. I'm going to have a kind of an uncomfortable reaction to it. And that can be a big turnoff to people. Another thing that is frustrating with these medications is they do not work quickly. Antidepressant medications, really, you have to give it about 4 to 6 weeks, and sometimes even longer, sometimes 8 to 12 weeks, to really get the benefit in improving symptoms of depression and anxiety. However, it's not that you're not, it's a gradual improvement over that 4 to 6 weeks or 8 to 12 weeks. So you may notice that certain symptoms that you're dealing with get better. So things such as like energy and appetite and sleep, and those are the symptoms of depression that tend to improve first. And then when you stick with the medication for that appropriate time, that's when the symptoms of anxiety start to lessen, depression starts to lift, and the person will start to feel better. But yes, the first few weeks, side effects, primarily headache, stomach ache, just feeling a little bit anxious. Those are very common, but they do tend to dissipate. Some of the I'd say more chronic side effects, or side effects that can occur over time, or side effects that can persist with use. A lot of people do unfortunately struggle with sexual dysfunction related to antidepressants. So they may lose their sexual desire. They may lose their ability to orgasm, called anorgasmia. So there are sexual side effects that are not often talked about, but impact a significant of people who take antidepressant medication. And as clinicians, there are things that we can do to reduce those, whether changing the medication or adding a small dose of a medication to reverse those effects. Those things are manageable, but unless a clinician is really looking for it, it's not often reported. Another side effect that a lot of people are concerned about is weight gain. There are certain antidepressants that we really can expect a person to gain weight on. But the majority of antidepressants that we have, we don't anticipate people to gain a significant amount of weight. That most in the classes that we use frequently are what we call weight neutral, meaning they don't necessarily help you lose weight, but they don't necessarily cause you to gain weight. However, there are, of course, instances where someone is not eating a whole lot due to their depression, and then we treat their depression improves, their appetite increases, and then they gain weight. So we really, we just encourage people to stay active, to keep with a healthy diet as much as they can. And be aware that, this is possible to happen, but it's not likely. But just keep an eye on yourself. Notice if you notice any changes in your eating patterns, or if you begin to develop a drastic weight gain or loss, and that's something that you would want to bring up with your clinician.
And Aaron, we're starting to get questions from our community, but before we get to them,
sure.
Does every person with depression need to be on medications, or can depression be treated without?
That's a really good question. So first-line therapy for a mild depressive episode, and even a moderate depressive episode, is psychotherapy or counseling. And so if someone is not to the point where they are, I'd say, experiencing suicidal thoughts, or even if they are, if the clinician determines that their risk is low, then psychotherapy may be just as effective, if not more effective, for those people who have mild depressive episodes. I think people who are in that moderate to severe episode of depression, most people will do best if they have a combination of medication and therapy. But medication is not always an option for some people. Some people, potentially, they've tried medication and they can't tolerate it. They have side effects that are, uncomfortable or just undesired. I get this a lot of times. People will say that they want to take a natural approach. They don't want to use medication. So there are plenty of non-pharmacological options that can be used, at least initially, to address depressive symptoms. And even myself as a pharmacist, I am always looking to use the least amount of medication possible, and encourage people to explore other routes that potentially get to the root of their anxiety, the root of their depression. And cognitive behavioral therapy, talk therapy, just counseling, group therapy, there's many different avenues that one can take. But sometimes the medication is helpful to even getting them to consider those types of avenues. It's a tool. The medication is a tool in treating your illness. And the people who have the most improvement and the most success in recovery are people that are addressing their depression from a variety of different angles. So having a medication that works well for you, having a supportive therapist, having friends and family, eating healthy, getting enough sleep. So there's a whole wide parameter, or many different things that factor into how well a person is feeling, I guess, emotionally and mentally. So medication doesn't have to be included in that, but for people who are suffering, there's nothing wrong with having a medication and continuing it for at least a year. So I encourage people to stay with the medicine at least a year, as long as they're not having any uncomfortable side effects, before they can consider coming down on their medication. And my student Saprit did a journal club on an article that was published not that long ago, looking at the rates of recurrence of depression among people who are stable, they're in remission from depression, and they have a desire to stop their antidepressant. And so they found that about 50% of people who stop their antidepressant will have a recurrence of a depressive episode within a year's time. So it's definitely something to be aware of, that if you stop your medication, these symptoms can come back. But also, a lot of people do have a desire to come off of their medication. So I would, if someone is thinking about that, I would encourage them to have those other modalities in place before you remove the medication.
Mhm. And talking about natural remedies,
Mhm.
I don't know if we can consider cannabis as a natural remedy, but it's one of the questions here. If it's
Yeah.
effective to treat depression, and
Mhm.
what's the long-term effect? Is dependency one of them?
Sure, that's a really good question, and it's a question that I answer probably 4 or 5 times a week on the unit. So up until or at this point in time, we don't have enough evidence, clinical evidence, not enough research to say that cannabis truly is effective in treating anxiety and depression. Um, if you talk to people who use cannabis, they will say that it has a relaxing effect. It helps with my anxiety. But the research that we have to date is not definitive one way or the other. We know that people who have mental health conditions are more likely to use cannabis. So it's hard to in understanding what that means is depression or anxiety. Is that is cannabis causing anxiety or depression, or do people with anxiety and depressive illnesses find benefit from this, so their use is increased? In terms of what we do know about cannabis in mental health is that younger people, I'd say under the age of 25, 24, when the brain is still developing, there is definitive evidence to show that high potency, frequent use of cannabis containing products increases the risk of developing psychosis, which can then progress to schizophrenia. So it's definitely a concern amongst our young people. When the brain is still developing, they're sensitive to the psychoactive component of the cannabis plant, the THC, and it really can trigger periods of psychosis to the point where the patient is hallucinating, they become very paranoid, and this is something that we see in the emergency department quite frequently. And not only are we concerned about cannabis in young people, but it's also exposure to drugs that are meant to look like cannabis, but are in fact not cannabis. So the one that I'm referring to in particular is K2 or spice, which is a synthetic cannabinoid that is manufactured in a lab, and it's sprayed on potpourri or a substance that is leafy and may resemble marijuana and is smoked, but it is not at all, in terms of how that drug works, is very, very different than THC. So this this can cause a pretty severe, pretty significant episode of psychosis that usually resolves with treatment, but even with treatment, sometimes it can take several weeks for that person to return to their baseline. And it really does kind of alter trajectory in the person's life if they experience something like that. I'm hopeful in the future that we have more evidence to support the use of cannabis or CBD containing products in the treatment of mental health disorders. But at this point in time, we really don't have enough evidence to say that. And we do have to be careful because we know there are risks associated with these substances, especially in younger people.
Thank you for that answer. And then Ruth, one of our attendees, is asking, most of the literature I have read states that antidepressants are not very effective, that what most people feel or experience is a placebo effect. Is that true?
So it's a really good question. It's a very good thought. So if you read any trial that compares the efficacy of antidepressants, you'll find that there is a very, very large placebo response rate. And so, yes, it's definitely possible that placebo effect is involved. And also, it's important to understand that for about 50% of people will not respond to antidepressant treatment, or at least the first trial. It often takes multiple medication trials before you find a medicine that is both well tolerated and effective. And, when we're looking at how effective a drug works, there's something called effect size. So if something has a large effect size, then we can expect a large improvement. The effect size for antidepressant medications is relatively low. So if they do find an improvement, it's not something that is a drastic improvement. And this is something that we try to be realistic with our patients, that this can help you, this can help get you out of what you're feeling right now. But in order to really achieve remission and to prevent your symptoms from coming back, it's the behavioral things that you have to take into account. It's making sure that all of those other aspects of your life are addressed, because you're right, the antidepressants all in all are they're not very effective for a lot of people. And so that is another hesitancy, is like, man, I just don't know how much this medication is going to help me. And there's several factors that may influence that. A new area of study where we don't have definitive information yet, but it's something called pharmacogenomics, and it looks at a person's genetic makeup. And the idea was, if we understand how someone's body breaks down different antidepressants or different medication, then maybe we can find one that would be a better fit than another one. And so that research is still underway. At this point, the most utility we receive from pharmacogenomic data is on how to dose a medication. Someone may be what we call a rapid metabolizer, so their body may get rid of their medication very quickly. And if that's the case, they may require a higher dose of the medication. On the other hand, someone may be a poor metabolizer, so they may require a lower dose, because doses that are in the normal range, or the range that we use frequently, may cause them more side effects. So, I agree with you that, these medicines aren't always incredibly effective. But if you find the right one, it can have enough of a benefit that people will want to stick with it.
Mm-hmm. And is it true that once you start taking depression medications, like you're going to have to take more and more to feel the effect of the medication?
Yeah, that's a really good question. So I mentioned a few minutes ago, when we start a medication, we usually start at a low dose and then gradually increase it. So from research, from experience, we have a kind of a goal dose in mind, like a target dose. Like most people, if this medicine is at this dose, will start to notice an improvement in their symptoms. However, that's not the case for everyone. If we get to a dose that we think is a therapeutic dose, but the person has been taking it for 6 to 8 weeks and they don't notice any benefit, then it may be time to give up on that medication. If we've maintained someone at a therapeutic dose for 6 weeks or so, and they notice a small improvement, or they notice some improvement, but they still have a ways to go, then that may be a reason for the clinician to increase their dose. Most medications will have like a maximum daily dose, or a dose that, we really try to avoid, because if we go to that dose or beyond it, that's when side effects begin to be more common. So a lot of it will depend on how well the patient tolerates the medication. If they're not having any side effects and they're getting, benefit from the medication, just not quite all the way, we may gradually increase it. I don't know if I necessarily describe it as a tolerance. Like there are certainly medications where a physiological tolerance develops. But in terms of antidepressant use, there's lots of things to factor into, I would say. So if someone has been doing well on, let's say, 100 milligrams of Zoloft for a really long time, but then all of a sudden there's a life event that is stressful, and there's a new sources of stress and anxiety in that person's life, then a dose increase is not out of the question. And it could be a temporary dosing. dose increase. You could try it at a higher dose for a few weeks, a few months, see if there's any improvement, and then gradually come back down. Occasionally we'll, in that type of scenario, we'll add on another medication that works slightly differently, but hopefully that medication combination may work better together than either agent by itself. So there are certain things that we can do to address this. I guess one thing, while we're on this topic, I should mention that it's not recommended to abruptly stop taking an antidepressant. So if one stops an antidepressant quickly, a couple things that you have to worry about. One is the reemergence of symptoms of anxiety or depression that's sometimes worse than the initial presentation. So that's something you want to be mindful of. Next is antidepressants, if they're stopped and not gradually tapered slowly, can sometimes have a withdrawal effect, something that's called antidepressant discontinuation syndrome. And this is not at all a dangerous or life-threatening experience, but it can be uncomfortable. Patients may have headaches or stomach aches or feel like they have the flu, have body aches. There's something that's been referred to as like electric shock sensations. So it's just kind of like it feels like a jolt is going through their body, and it's not at all dangerous, but if you're not expecting it, it can be very frightening. So that is, related to a rapid discontinuation of antidepressant medications. Yeah. Does that answer the question?
Yeah, absolutely. And time flies when you're having fun, because we only have 2
Sure
minutes left, and I feel like I still have so many answers for you. Postpartum depression, is that the same as major, or should we treat that differently?
Sure. So postpartum depression may, so let's first define that. So depression that occurs, usually it begins towards the end of pregnancy, but it can last up to, it's usually diagnosed within 6 months after childbirth. But the symptoms of postpartum depression may differ slightly in terms of, or in comparison to major depressive disorder. Symptoms of postpartum depression that are similar, lack of pleasure in doing things, limited energy, different sleep habits, but symptoms that women experience related to postpartum depression that may be different or not understood as postpartum depression could consist of intrusive thoughts. So having thoughts, I've spoken with women, they've classified them as scary thoughts. So thoughts of potentially harming the child, or thoughts that they would never ever act on, but are constant, recurring, and cause distress. So postpartum depression can have a significant impact on the family dynamics. So the mother's ability to care for the child, the mother's relationship with the child, and then the child's development moving on as they grow up. So postpartum depression is definitely something that is underdiagnosed throughout our country. And so clinicians, if a woman is pregnant or in the postpartum period, screening for postpartum depression is very important. And it can be as simple as, 1 or 2 questions. However, in my experience talking with women, these questions, I would encourage clinicians to dig a little bit. Because they're not always forthcoming about how they're feeling. There may be fear of repercussions related to their child. So I don't know, these postpartum depression can be really devastating to a family, but there's ways to mitigate it, or at least identify it and ensure that the woman has access to treatment that she needs.
Mm-hmm, mm-hmm. And Aaron, postpartum depression, I think there is a big of a stigma around it. As women, we're supposed to feel so happy because there is a new bundle of joy in the home.
Right.
And it's like you have to hide, these feelings, but not only for postpartum depression. I think that in general, there is still a stigma. I think that we've done great advancements in that, but there is still a stigma. Mm-hmm. So do you have any tips for all of us here in the community, on how to probe people that we think need help to talk about it, or how do we, if we feel that we might be suffering from depression or anxiety, how do we talk to people about it? And then again, if somebody talks to us, how do we embrace that conversation without making the other person feel threatened?
Absolutely. Yeah. And that's a really hard question. And
I know.
I think it's something that over time, we're starting to get better at. I think, in my own practice, when I'm dealing with, whether it's colleagues or patients or family members or friends, I'm trying to be very open about things. Like if I in my life, I've experienced periods of depression and anxiety. So I'm very, very open with my own experiences. And I think that I'm able to relate to people from that regard. In terms of, another way to approach it is simply being there to listen, not necessarily providing any type of feedback, but just listening. I feel like giving someone your ear, letting them tell you what's going on can be very helpful. It also, just being able to talk about it. So on our psychiatric unit here, I do groups twice a week, and really, the goal of the group is to educate patients on medication, but it ends up turning into a conversation very similar to like what we're having today. Is, how do you handle your symptoms of anxiety or depression, or do you have someone that you can communicate with when you're not feeling very, very good? We talk about identifying, warning signs. Is there anything that you do that you can start to tell that you may be headed in the wrong direction? Do you isolate? Do you sleep more? Do you start to use alcohol more frequently? Things like that. I encourage people to find those people in their lives that they can share these things with, but unfortunately, not everyone has those. I think our providers here, or the outpatient programs that we have for patients once they leave the hospital, do a pretty good job of, trying to engage people, like, and they encourage them, if someone, or you have a friend who's struggling, like, I give them our information, allow them to reach out to us. I think talking, I've said this kind of over and over again, but really just talking about it, allowing someone to, like, creating a space where someone is comfortable being a little bit vulnerable with you, sharing things about themselves. I think if you create that non-judgment-free environment where people are just open to share their experiences and feel like they're being heard, I think that can go a long way.
Mm-hmm. And Aaron, I think that will be great wrap up. So you just said they can call you.
Yeah.
Call the group. So what's the phone number? I want to write it down in the chat.
So, I mean, I can get like my office number. Is that what you're referring to?
Or here, people at Montefiore Naya, where do they reach out if they feel that they need help, or if somebody needs to reach out? I know there is 1-800 something help, I think.
Yeah. I mean, I know I can, I may have to look up the best number to call. But if someone truly is in crisis, we have of course the suicide hotline. So that number, I cannot remember off the top of my head, and I really should know it. But it's a number that someone's always there. And if you feel like you're in danger of hurting yourself, or you're experiencing crisis, that is a great resource. Those people will stay with you. They'll listen to you, they'll talk, and they can help you get in touch with the community resources that can help.
I got it.
Oh, wonderful. Thank you. Yeah, that's
yeah, I knew it.
Another resource I'm gonna type in chat is NAMI. I'm not sure if anyone is available or has heard of NAMI. But not only is this helpful for people who are suffering from a mental health condition, but also friends and family members. There's lots of information about medication. There's information about group support programs, and really lots of valuable resources. So I often will direct patients towards that site. It has a lot of useful references on it.
Yeah, correct. And let me see, okay. And then you can call the hospital too and ask for the recovery center, right?
Yes, yeah. So, if you're dealing with substance use issues, our recovery center does a great job.
348 2000. So let me write it down too.
Okay.
Be good. 845 348 2000, and you ask for the recovery center. Perfect. Again, time flies when you're having fun. Aaron, can you come back? Because I feel like I still have so many questions. I'm sure the community has. This is a very interesting topic, and I don't think that we talk a lot about it. And that's one of the reasons why there is so much stigma around it, because, people just want to hide it. We don't want to talk openly about it. There was something else that you mentioned, schizophrenia, and how younger people who are using cannabis and all of that kind of start suffering from that. I think that's a very interesting topic on how all these drugs can affect young people's brains and the consequences that we might be seeing 20 years from now. I don't know, now that marijuana is legal, and when I go to the city, I smell it all over the place. I wonder if in 20 years from now, all these kids are going to be paranoid. I don't know. I'm just speculating.
Yeah, no, and it's something that I've thought about as well. And I'm kind of observing how younger folks coming into the hospital for episodes related to cannabis use. So
12, 13-year-olds I've seen. So it's a scary thing. So we'll talk about that. So you're invited again. People, attendees, thank you so much for being with us today. Aaron, I'm super thankful. Thank you so
thank you for having
much.
me. Really appreciate
it. Seriously, I'm going to call you very soon, and we're going to set up another day.
You know where I live here. So
yeah, absolutely. And then please join us next week, because we're going to have more fun. We're going to be talking about strokes and how to prevent strokes and what to do if there is a stroke, because we have no time for a stroke. That's the title of our new, our coming community chat. So thank you so much to all, and I'll see you next week. Thank you, Aaron.
Thank you.